spring and everything. So the nurse would place this on the back side of the cervix. It's gonna secrete hormones and help ready that cervix for labor. It typically stays in for about 12 hours, and then we will use the string to remove it, and all is well. That is your cervical, okay? So we do that. We place her high dollar cervidil, and we leave it in place for 12 hours, and now we have orders the next morning. So she has an uneventful night. The cervidil is removed. She is allowed to shower. Her cervix is now 270 in a -1 station. Did it help? It's better than we were. I'm also gonna say that her cervix is anterior and soft, so we'll make it a little bit better, okay? Baby's in vertex presentation, which means what? Head down, which is a requirement to continue this process. She's having some irregular contractions, and the doctor gives us orders to start Pitocin or oxytocin. Those two terms are used interchangeable. So oxytocin and Pitocin, one's synthetic, one's natural. We use them interchangeable, so either one's fine. If you are given oxytocin, it has to be on the pump and titrated very carefully, and the mom has to be on continuous fetal monitoring once we start oxytocin. Okay? And you will never, ever, 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 ever bolus in oxytocin with a baby on board. Now, we do bolus it after the placenta because we're trying to clamp the uterus down. But if you do that with a baby on board, you're gonna put them into distress, okay? All right, continuous fetal monitoring, continue the penicillin, Stadol, and can have an epidural when ready. Normal 7 at 125 to keep her hydrated and to keep her MPO in case we need to proceed with a C-section. Very good?
Is there any reason a woman would say not to give an epidural? Or
Not usually, we're pretty lenient on our epidurals. There may be a contraindication based on the patient's status, but the physician's gonna allow it if they want it. Like, for instance, they say may have epidural, but then anesthesia comes in, their platelet count's low, and they not give it because of that. But the physician was okay with having it. It was safe.
When can you not give epidural? What is it considered to be?
There's not a hard and fast rule, but the patient has to be able to sit up and be safe during the process. So I've seen them hold them when they're 4 to 5 centimeters because the patient's thrashing all over the place and it's just not safe. But I've also seen them give them when they're 8 to 9 centimeters because the patient could sit up and be still. So it's more of a safety issue. Typically speaking, we do them usually more commonly between 4 and 6 centimeters. Any other questions? All right, you'll notice at the top it says non-stress test once reactive begin oxytocin. So let's talk about what that means. So here's our strip. So non-stress test is basically just put the mom on the monitor, evaluate the baby, and if it meets the criteria, we call it reactive. It's a way of us to say the baby looks okay. So I'm gonna give you the criteria and then I'm gonna explain it. So in order to be reactive, which is what you want, you need to have 2 15 by 15 accelerations within 15 to 20 minutes. Okay? So to be considered reactive, which is what we want, they need to have 2 15 by 15 accelerations within 15 to 20 minutes. So for testing purposes, you're just gonna have to evaluate it on the strip that is provided to you, which is probably a little less than 10 minutes, but it'll either be reactive or not. Now, let's go through our process. Is the patient contracting? She's not. This is fetal movement. That's not a contraction. So she's not really contracting, at least not on this strip. What is my fetal heart rate if we were to pick this area? Give me the top and the bottom number.
40, 130.
Okay, I heard 130. I'll take that. I'll even take 130 to 140 because I like that. It's more easy to round. You could even say 130 to 145 because of that little uptick right there, okay? Let's do 130 to 140 because it makes this a lot more easy. So 130 to 140, moderate variability. Everybody agree with that? Mm-hmm. If I average 130 to 140, I would get 135. So to meet the criteria, it needs to go 15 beats above the baseline and last for 15 seconds. So if it is 135, it would have to hit what? 150 and last for 15 seconds. So each box going across is 10. So essentially it would have to go up 15 beats and last for at least a box and a half. Pretty good? Alright, so does this one hit 150?
Yep.
Does it last for at least a box and a half?
It's right at it.
Okay, does this one hit 150?
Yeah.
Does it last for a box and a half?
Yes.
How about this one? It's weird down here, but that's also part of your A cell, so technically it does, but I only needed 2 anyway. Is this strip reactive?
Yes.
It is. So that tells us that our baby's happy and healthy and we are good to proceed on with induction. If I had to give it a category, would it be category 1, 2, or 3? It is 1, because everything looks good. Okay. Real good. Y'all are handling it really well, so I appreciate that. This was about the time that the day cohort was just like, I don't know if I'm good or not. I don't know.
We're used to being.
Shovel it down your throat, right? Alright, so let's talk a little bit about, we already mentioned your IV narcotics and did that, so let's talk about oxytocin for just a minute.
It's the devil.
It is like, if you're having an induction, it is a different, it's a different experience. At least if you go into labor, your body releases some endorphins, we just flip a switch and like, labor on, here we go. Alright, so oxytocin, why do we give it? To induce labor. It has to be on the pump, has to be titrated very slowly. They have to be on continuous fetal monitoring, and you are never, ever, 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 ever going to bolus it with a baby on board. Okay? Biggest side effect that we see is obviously gonna be fetal heart rate decels or stressing the baby. For mom, it is water intoxication. It's the reason they look like the Stay Puft Marshmallow Man the next day. Okay? So that will clear itself out, but they will usually have some swelling the next day. And the longer they're on oxytocin, the more likely they are to have a postpartum hemorrhage.
They can take it, diuretics.
And they'll be given Pitocin for the postpartum hemorrhage. But
Diuretics when you-
not usually. Usually within about 6 to 8 hours, they will start naturally diuresing themselves, and then by the next day, they look more normal, so.
If not, like nurse says, massage the fungus.
Do what? Massage, yeah. We're gonna talk about massaging the fundus. Alright, so let's talk about this strep. So it has been 2 hours since we started the oxytocin. Is she contracting?
Yes.
Is she contracting regularly?
Yes.
Also yes. What is do I have a normal fetal heart rate?
Yes.
Yes. What would you consider your variability? Minimal, moderate, marked, absent? It is moderate. It almost looks a
Moderate.
little minimal right here at the beginning, but we're gonna go moderate because that's what it looks like over there. Do we have accelerations?
Yes.
Okay, do we have decelerations? Is it reassuring?
You gotta go slow.
Alright, so let's pick a spot. Let's go right here. What is my fetal heart rate right here? Give me 2 numbers.
120.
120,
120.
120 to 130, 120 to 129, 120 to 128. It's still gonna get you about the same thing. So it is moderate variability because there's at least 6 beats of difference, right? And then we do have a beautiful acceleration right here. There's a little bitty one right there. Well, that one's beautiful. Do we have a decel?
I don't know if those are considered
Okay.
decels or not.
Little baby decel.
No, we don't count that. No, it's gotta declare itself. It's gotta be obvious. Here's the other thing I do want y'all to know. When you're doing your baseline, you can't count in a decel or a acel. And if you have an acceleration that's attached to a decel, it doesn't count either.
Okay.
It's considered an overshoot. Yeah, we don't count it, okay? Overall, do we feel like this fetal heart rate is reassuring?
Yeah.
Yes. What category would you give it?
Was
It's
that
category
category
1. Everything looks good, right? We don't really didn't identify anything that was wrong, so it is a category 1.
Can you show me the accelerations again? Are there 2?
There's one here, and then there's this little bitty one right here, which doesn't count for a whole lot, but it's there.
And how do we know that's not a decel in the middle?
This,
Yes.
it's not just because.
It's attached to the acceleration.
It has to be, like, that's just a variation in the baseline.
It has to be longer?
Is it like 30 seconds?
It's essentially.
Like more prominent?
It would be longer than that, yes. Let's go with that. That's a
How
good
do I know this
explanation.
is not two, right here, because it goes up and down and then up again? No, the first, to the left. That, how do I know that's not two
Okay.
different things going on?
So, I know.
Are these stupid questions?
So what what would be helpful, if I could do it, would be to turn this sideways so you could look straight down it. And what you're gonna see is that the baseline falls here, that's just an A cell with another A cell.
So
It's
it's
just two
two.
A cells, yeah.
It's a what early.
So there's three A's.
Technically, you could call it three, yes, I'm okay with that. I'm not gonna get that specific on a test.
It's a
So
early.
you wouldn't ask us how many egg cells are on?
No, never.
Oh, okay.
So on the test, you just want us
That's
to
great.
identify if it's an A cell, B cell, or variable.
Depends on how to go. A lot of times, it's just evaluate the fetal heart rate tracing and what are you gonna do about it?
Oh,
And that way, if it just has two, it's just fine.
Fine.
Okay.
Do we need to do anything about this strip?
no.
Category one strip,
We're good.
we're gonna do the equivalent of do nothing, which is
Monitor.
document and continue to monitor. Okay?
Baby's coming sometime.
It'll be here when it gets here, right? Alright, 2 to 3 centimeters dilated, she's 70% of phase and a -1 station. If she's 2 to 3 centimeters dilated, what phase of labor are we in?
One.
Stage 1, phase 1, which is laden, okay?
Not really labor yet.
4 hours later, there's only so many strips I can pull. It looks exactly the same, so it's fine. We're gonna move on, okay? She is now 4 centimeters dilated, 70% of phase, and a -1 station.
So now she's going into.
Now she's in active labor, and guess what? She would like an epidural.
Of course she was.
She's when they start acknowledging,
That's right. So let's talk about epidurals. So epidurals are used for labor, spinals are used for C-sections. The nursing care of that patient is exactly the same, the procedure is slightly different. So I'm gonna talk about epidurals and then we'll mention spinals a little bit, okay? Epidurals, we need to make sure that there is an informed consent on the chart. It is invasive. We need to check a platelet count. It needs to be adequate because they're putting a needle in a pretty vascular area. And the biggest side effect that we see from an epidural or a spinal is maternal hypotension. So if you're working med-surg and the patient's blood pressure dropped, what do we typically do to treat it? Give them a fluid bolus. So with these patients, we're gonna do a preemptive strike and we're gonna give them a fluid bolus to hopefully prevent it, okay? So informed consent, check their platelet count, and administer a fluid bolus. It is usually 700 to 1,000 milliliters for this bolus. Once we have done those things, we will call the provider, so this will be done either by anesthesia, like the anesthesiologist, or the CRNA, and they will come in and get ready to do the procedure. We will then position the patient in a position known as the dangle position. It can also be done in a sideline fetal position, but that is less common. So we put them in this position that you see, a support person in front of them, really bad posture, curled around their baby. We're trying to open up those spaces so it makes the procedure a little bit easier. When they set up, you're gonna put 2 pieces of equipment on them. A pulse oximetry monitor and a blood pressure cuff. Why do you think we put the blood pressure cuff on there?
See if they get hot.
Because it can cause hypotension. Once we have confirmed, done our timeout, checked our platelet count, which hers was 206, by the way, is that an adequate platelet count? So we're good, she has a consent on the chart, everything's fine, she has no allergies. We're gonna proceed with the procedure. They'll put a drape on the patient's back and then they will numb the area. That's usually the worst part of the procedure because it's gonna burn, okay? So they're gonna stick and burn, numb everything up, and then what the patient usually feels after that point is gonna be pressure when they insert the needle. It is a long needle. And then once they get into the correct spot, they will thread the catheter through that, and it's pretty flexible, and then the needle comes out. There's 2 things that we need to be mindful of, okay? The first thing is the test dose. So because this is done completely blind, it is possible that that little catheter could have migrated into a vessel. And the medication that we give through their epidurals, at least at my facility, is ropivacaine, and cane drugs do what? They numb. And then fentanyl, which is a high-powered narcotic. And if that were to be given continuously through their vascular system, they are gonna crash, okay? So we need to confirm that they are not in a vessel. So what we do is, or not we, they push epinephrine through that catheter to see if there's any change in the maternal heart rate. You do not wanna change, right? So if they're gonna do a test dose, they'll say, can you tell me what my mom's heart rate is? Hence the pulse oximetry monitor. Let's say it's 85, right? They give the test dose and let's say it goes up to 92. That's fine, that is not a change. But if it was 85 before and now it's 145 or 135, that's a significant change. So if there is an increase in the heart rate, they would take everything out, they would get a new kit, and they would start all over.
And they don't just back it out.
Do I?
They don't just back it out.
Nope, start all over.
Have you seen?
It is rare, I've seen it once, but it is very rare. All right, once we've confirmed that we're not in a vessel, then they will give the first dose or the bolus dose of medication to help start to get them comfortable, okay? It is not sutured in, the epidural is taped in, so just be mindful if you're helping move the patient in labor and they have an epidural, if you slide them across the bed, it can kind of roll up that tape and dislodge that epidural. And they tape it really good, but it is possible, so just be careful. The epidural works by gravity. So ideally, we would lay them supine, but Ms. Capeless said you can never, ever, ever lay them supine. So what you're gonna do is tilt them, okay? We call it a hip tilt or a hip wedge. You want them as close to supine as you safely can get them to keep that medication working pretty evenly. If there's one side that's less numb, that needs to go down first so that more medicine gets to that side. And then we will just reposition them, usually every 30 minutes to an hour, to keep them nice and comfortable. Okay? And what did we give them before we started this procedure?
Fluid.
A lot of fluid. So what do you need to make sure that you do? Please put a catheter in them because now they are numb and they do not realize that their bladder is full. So once they are good and comfortable, we will place a Foley catheter. Okay, very good. Let's talk about hypotension. Let's talk about some symptoms that the patient is becoming hypotensive. One of the most common maternal symptoms that you will see is I'm fixing to throw up. I am nauseous, okay? And if we don't take that hint, then the next one's gonna be, I do not feel well, I think I'm gonna pass out, right? So nausea is very common. So if you have nausea right after an epidural, check the blood pressure. You can also see fetal heart rate decels, because again, if mom's blood pressure drops, the body says, well, let me shunt blood to all the things that mom needs, and the uterus is not one of them, okay? So nausea, change in level of consciousness, or I feel like I'm gonna pass out, and then fetal heart rate decels are the most common things that we see. A lot of times the heart rate will decel before the mom is even symptomatic. What do you think we do about it? Oh, give them some more fluid, right? So we're gonna give them another 300 to 500 cc bolus. But if that doesn't work, or we need to intervene a little bit more urgently, we can give them medications like ephedrine, that is a vasopressor that helps to bring their pressure up. So epidurals are gonna dilate, and we can give them a pressure drug to vasoconstrict them, and that'll bring their pressure up quicker. So there are medications that we can give. For us, as the nurse, the care, regardless if it's an epidural or a spinal, is the same. Same side effects, same positioning, all of that's the same. But let me talk about what the difference is. So the procedure is slightly different. It uses a smaller needle, and they actually go all the way into where they would get cerebrospinal fluid. So for a spinal, you will see cerebrospinal fluid drip out of the catheter. They will put the medication in, and then the needle comes out, there's nothing left in their back. An epidural, they're gonna have that catheter, okay? If they do a spinal, they are going to be profoundly numb in about 15 seconds. And that's gonna last for about 2 to 3 hours, give or take. And then their feeling is gonna start to come back, okay? So spinals are used for C-sections, you're not gonna use them for labor. Epidurals can be used for labor or a C-section. Let's go with that. So we get her epidural, and she's nice and comfy. We put her Foley catheter in, all is well, and the physician comes in and says, let's break water. So let's talk about some terms. So if the patient breaks water on their own, it just happens, that's known as SROM, spontaneous rupture of membranes. If the physician does it, cause it's out of scope of practice for me to do it, that is artificial rupture of membranes, which is what we're fixing to do. If I'm checking their cervix and they rupture, that is still spontaneous rupture of membranes. Alright, there's two options for breaking their water. The one on the right is an amnicot, which is like, it looks like a little condom, for lack of a better way to put it, that goes over their finger and it has that little edge on it that will allow them to break water. We don't see that used very often. This is the amni hook, which is more commonly used. It's like a crochet hook.
I was about to say a latch hook.
Yeah. If they're gonna break water, then we do need to monitor a few things. So the big one is gonna be check the fetal heart rate before and after they're ruptured. And we'll talk about why in just a minute. We're also gonna note the time that they ruptured, the amount of fluid that was present, the color of the fluid, and if there was any odor. So let's talk about rupture of membranes and what one of the risk factors is for that. So the complication that you can see when a patient ruptures, if it's spontaneous or artificial, is that you can have a prolapse of the cord. So nobody wants that to happen, that's a medical emergency. Now, if you were to do a vaginal exam and the baby's head is sitting right on the cervix, you're not gonna get a prolapsed cord. There's no way for that cord to come around. But if that baby's head was way up here and you had all this room and you break that water, it's very easy for that gush to pull that cord down. So a high station, like -3, -4, at the time that they're ruptured, increases the risk of a prolapsed cord. So we would rather not break their water until that baby's head is well applied to the cervix, okay? That is the reason that we check for heart rate before and after. Because if that cord came down, you're gonna see a change in the heart rate. They're probably gonna have a deep variable, or they're gonna have bradycardia, because once that cord is compressed, it's gonna change the heart rate, okay? Now, let's talk about color. Color of fluid should be technically clear. It is not gonna be clear like a bottle of water, okay? It has an ever so faint yellow tint to it, because it is a lot of baby pee, okay? But if we call it clear, just take our word for it, it's clear. The other two options would be meconium stained, which is green, and red, which indicates bleeding. So you want it to be clear. If there's meconium or there's blood, the physician needs to be notified. If they're not already there. What is a term?
Is that like infection or?
No, so meconium is actually, by definition, the first stool that the baby takes. So if they're 41 weeks, like our mom here, it could just be that the baby's doing what it should be doing, because it should have delivered a week ago. So it could be coincidental that they have meconium, or it could indicate that the baby's been stressed out in utero. Either way, if there's meconium, can get down in their lungs and cause infection. So if there's meconium present, there's gonna be a higher risk of like pneumonia and respiratory infections. And then of course, bleeding is what red's gonna indicate bleeding, which needs to be, the physician needs to be notified. Once they are ruptured, they are also on a timeline, okay? So we like for our moms to be delivered within 24 hours of the time of rupture, because we have now taken away that protective coating around the baby, so they're gonna be higher likelihood to have infection. So we're gonna make sure that we monitor them closely for fever, and we hope to get them delivered within 24 hours. Pretty good? Ready for another strip? This one stresses me out a little bit. Even though I know it's a fake strip, it still stresses me out. Okay, so the patient is now 6 centimeters, 80% a -1 station, and this is about 15 minutes after we ruptured them. So let's just go through the different things. Is she contracting regularly?
Yes.
Yes.
Yes. Let's all look at the same spot, because depending where you look at it on here, you're gonna get a very different answer. Let's do this for our fetal heart rate. Give me two numbers. Well, I don't love that either, but let's just go with it.
145 to 1.
Okay, I would say 155 to 165-ish, if we take just this part right here. Okay, so is that minimal or moderate? It is, it's moderate. Do we have A cells?
Yes.
2, maybe.
Yes.
Okay, I'll take two. One, they're little, but we'll give them credit for them. 2 A cells. Do we have B cells?
Yes.
What type?
They're
Those. That is a variable. Those are severe variables, but they are variables because they're very abrupt. Tell me what a normal fetal heart rate is.
110 to 160.
Tell me what that heart rate is at the bottom of that D cell in the middle.
too low.
So you went from, I know what 30 sounds like.
Yep.
Okay, that is a severe variable. What are you gonna do about it?
Strip three, brains.
Run in there. What's the first thing you're gonna do about it?
Change positions.
Service.
Change position. I'll even take cervical exam because we just ruptured her, but change position and somebody can check the cervix while they're flipping her on the side, okay? So change position. Do we call the physician? Do we do all the other things? This would be an example of variable D cells that require all of the interventions. Okay, first intervention is gonna be to turn them, but then I'm gonna give her some oxygen. We're gonna turn that Pitocin off, right? I'm gonna give her a fluid bolus, make sure this is not something to do with her blood pressure. And regardless if they correct, I'm going to call the physician and say, hey, you wanna pull up that strip and see what you think, okay?
Would this be considered a category 3 for the brain?
Still a category 2, okay? Because it is not absent with late, so it has to be one of those 3 criteria or it falls into that. It's still bad,
Yeah.
but it is a category 2 technically, okay?
I like the categorization.
Category 2 is absolutely useless, but it is what it is. All right, y'all go with that one? Does everybody feel at least a little bit better about recognizing things? Great, let's do it again.
Given 2 numbers, why are we looking for 2?
So typically, we would express it as 1, but in order to calculate variability, it's easier to give 2 numbers and see how much difference there is. So I could also call this 160 with moderate variability. That would also be okay. But for y'all, calculating with 2 numbers allows you to tell me what the variability is. Yes?
Could this not just be a regular D cell because it's happening at the time of the contraction?
So it is a variable because of the way it looks. Variables often happen with a contraction, but don't have to. But if it's late or early, it would definitely have to be the way it looks with a contraction. Okay? 2 hours later.
So would that be what you're talking about, the contraction?
She's looking better.
It is, this one's different.
compression.
This is the head compression. So 2 hours later, we fixed her, by the way. We fixed those D cells. Everything looked good for the last couple hours. And all of a sudden, she says, hey, I think I'm gonna throw up. So this throwing up usually means they're entering transition, right? So nausea right after the epidural usually indicates a blood pressure drop. If they just randomly all of a sudden are like, oh my gosh, I'm so nauseated, I can pretty much guarantee there's somewhere between 6 and 8 centimeters, right? That's just when those hormones release and it's like, ooh. So she is 8 centimeters, 90% effaced in a 0 station. She is now in what phase of labor? Transition. And what can we say about this strip? Let's just go through the motions. Contracting, yes or no?
Yes.
Okay, fetal heart rate, let's all do the same area. Tell me what my fetal heart rate is right here. Can you count that A cell?
140 to 150.
Okay, let's do 140 to 155 would be okay, 140 to 150, somewhere within that range. What type of variability?
Moderate.
Do we have A cells?
Yes.
Do we have D cells?
We do.
We have 1 A cell, and how many D cells?
3.
Okay, and they are what kind?
Variable.
No,
Those are regular.
These are technically earlies. Now, I will say I try to leave my strips for the test that are textbook. These could be a little bit more rounded. I'll be honest, that last one looks a little variable, but we're gonna call these early, okay? For testing purposes, they will appear a little bit more subtle and rounded, okay? Showing so many strips I can pull. If we are classifying these as early, what are my nursing actions?
Continue to monitor.
Document and continue to monitor, yes.
Wait.
Go ahead and get some people involved, right? Get some people there, yes.
So variables, they have more of the V.
They do.
And then the earlies are like,
They're a little bit more rounded.
but it doesn't matter, like, they're not early before the contraction, they're still with it.
Correct.
Okay.
So early, still with the contraction. Yeah. 1 hour later, she calls you to the room, says she needs to push, she's 10, 100% in a +1 station. She is going to push for a total of 2 hours. She's gonna deliver a 9-pound, 3-ounce baby girl with a moderate shoulder dystocia and a 3rd-degree laceration. Okay? We will pick her back up in postpartum next week, but we're gonna cover this. She does deliver the placenta, so let's talk about, actually, let me go back. What is the max amount of time that the patient should be pushing?
2 hours.
2 hours. So if they are adequately pushing for 2 hours and that baby is not delivered, that is, that is a red flag to say maybe this baby is not meant to deliver from below, okay? When we move to stage 3, that is placental delivery. How long should this take?
30 minutes.
No longer than 30 minutes. What are the 3 signs the placenta has detached?
Gush.
Gush of blood,
Extended cord.
lengthening of the
Abdomen
cord,
change.
change in the shape of the abdomen, which nobody notices because there's a cute little baby sitting on top of her belly, but that is one of your signs. Let's talk about blood loss. So we used to do estimated blood loss, and then we found out that we were woefully underestimating their blood loss. So now we measure it. We do a quantitative blood loss. Let's talk about what's normal versus abnormal. For a vaginal delivery, it should be 500 milliliters or less. For a C-section delivery, it should be 1,000 milliliters or less. That's still a significant amount of blood loss, okay? Now, the way we measure this is at the time of delivery, they're gonna have a drape up under their bottom, and it's gonna have like a cylinder that is measurable, that is going to catch all of the things, okay? We do need to deduct how much amniotic fluid's in there. So for instance, let's say the baby delivered and there was a gush of fluid after, and it was like 200 milliliters. And then after the placenta delivered, it was a total of 700. You would just subtract the 200 from that. The physician usually does that. So for testing purposes, I'll just give you that number, okay? So let's say that she had 500 milliliters of blood loss that we could count. The other way that we count blood loss is gonna be to measure the weight of any pads or anything that we use. So we'll talk about that next week, but I'm gonna go ahead and give you the conversion today, just so you can, I don't know, marinate on it, I guess. It's 1 gram of weight equals 1 milliliter of blood, okay? So that is your conversion there. And then she will go into recovery, so let's talk about her recovery. So we're just gonna,
blood loss does it equal for them to intervene?
that's a loaded question. We are much more aggressive now than we used to be. And I would say once you hit that 1,000 mark, we better be doing something. Now for C-sections, they may have that 1,000 and not have any extra waiting after that. I'll be honest, from practicality reasons, if you don't intervene before they hit 1,500, it's like they tolerate it until they crash. And it usually is around that 1,500 mark. So if we notice their bleeding's heavier, we'll go ahead and do something immediately to try to prevent getting to that point. All right, so recovery. She has had her baby on her belly, and then those are your vital signs. Her current quantitative blood loss is 550, so she had a little more than we anticipated.
But she's geriatric.
I mean, she's geriatric, and she's 41 weeks, I mean, you know, all the things. What do we think about her vital signs?
Pulse is a little high,
Respiration.
but. Just had a baby.
She did push for 2 hours.
Respiration.
I don't see anything on there that I'm terribly concerned with, but let me just throw this out, right? So she's probably got a temp of 99.2 because she's had an epidural and she just literally did a marathon workout for the last 16 hours. She's probably a little bit dehydrated. So I'm not terribly worried about that unless something else pops up or it continues to go up, okay? Her pulse is slightly elevated, and it's easy to say, hey, that's just because she pushed the last 2 hours, and it may be. But let's talk about what it could be. So if she were to have some extra bleeding and she was gonna be symptomatic, what vital sign would change first?
Your heart rate,
And it'll do what?
it goes up because
It
of
goes up.
hypervolemic.
Right? Yeah. So the first thing that happens is the heart rate goes up because the body is going to compensate. The heart rate's gonna go faster to push more blood out, okay? Then you see the blood pressure drop. So we would like to catch it when the heart rate is up before the blood pressure starts to do a nosedive, because then it's harder to treat. So we would just kind of keep an eye on this and make sure that it does kind of settle down and we don't see any major issues, okay? Let's talk about risk factors for postpartum hemorrhage, since she's definitely got some, okay? All right, risk factors, having a big baby. So if they have a large baby, they're higher risk for postpartum hemorrhage. If they have a significant laceration, so we're gonna say 3rd or 4th degree lacerations, which we will cover what those mean next semester, but in the next semester, next week. Shoulder dystocia, anything that traumatizes the perineum is going to increase the risk of bleeding. The longer they're on Pitocin, the higher the likelihood they will have a postpartum hemorrhage. So let's go through those. Big baby, significant lacerations, so 3rd or 4th degree, shoulder dystocia, and use of Pitocin. I'm gonna add one that we're not gonna talk about this semester, but just so you'll have it for next semester. If they're on magnesium, they're also higher risk for postpartum hemorrhage. Magnesium is used for a couple of different reasons for high-risk complications, but it is a smooth muscle relaxant, so essentially it's relaxing the uterus, which makes it a risk factor. Right, good? Whew, okay, here we go. Remember Gracie?
Oh my.
Okay, so we finished with Reese, we'll pick back up with her next week. We are gonna talk about Gracie. So Gracie's admitted to labor and delivery from the office. Remember, she called, she was 33 weeks pregnant, and she was having some abdominal pain. We do a vaginal exam. She is 2 centimeters, 60% effaced, and a -2 station, and that is her strip. Is she by definition in preterm labor? She is. She is contracting and making cervical change. That is preterm labor, okay? The difference between true and false labor is, are they making cervical change? So she is truly in labor, and it's early, so it's now preterm, okay? So, let's evaluate her baby, and then we'll briefly talk about what we're gonna do with her. She is contracting about every 2 minutes. What about my baby's heart rate? It's kinda hard to see because it's so small.
140 to 150.
Okay, 140 to 150, I'll take that. 130 to 150, still gonna be moderate variability, right? Do we have A cells?
No.
Do we have B cells?
No.
What category strip would this be?
3.
It's actually a 1, everything looks fine, there's not anything abnormal about it. But she is in preterm labor, so our whole goal with her would be to stop her labor. And since this is normal labor, delivery, and newborn, maybe we'll see her next semester when you cover preterm labor, okay? So she's gonna go away. That leaves us with Keisha. So Keisha comes in and she delivers by primary C-section at 39 weeks. She has 2 little girls. Ava is 5'2" and Emma is 4'10". So I'm not gonna go through her whole labor process. We are gonna talk about the differences with a C-section, okay? All right, let's talk about some indications. What are some reasons that a patient would have a C-section delivery?
Previous C-section.
Previous C-section,
Is she doing 2 hours?
baby's too big,
They didn't deliver within 2 hours.
okay, so round peg, square hole, we call that cephalopelvic disproportion, okay?
Fetal heart rate drop.
Fetal heart rate, D cells,
Position of the baby.
condition of the baby,
Membrane and ruptured for more than 24 hours.
okay? Membranes have been ruptured and she's got a fever and we are not close to delivery and it's just safer to deliver by C-section, What would cause that?
Presentation.
Presentation. What two presentations do we choose to deliver by C-section? Transverse
And breech.
and breech. And then all of the high-risk stuff that you'll talk about next semester. So that's gonna include, placenta previa, placental abruption, prolapsed cord, and severe preeclampsia. So all of those would also be indications. Pre-op meds I'm gonna cover in a minute. I'm gonna go on down to incisions and then we'll hit these other points. So there is, typically where is a C-section scar?
Low transverse.
Low transverse, okay? If
That's
that
the new age.
patient is, do what?
That's new age.
Yeah, so if that patient is going to attempt a vaginal birth after cesarean, lovingly known as a VBAC, we have to confirm that their uterine incision is low and transverse. Cause you could have a mismatch, so we need to make sure that the uterine incision is actually low and transverse, which is more commonly done today, but we would need to confirm that. There is a classical incision, which is the one in the top right, which is up and down. Those patients are not candidates for a VBAC. So if they have a classical incision, most of the time, the only time you'll see that done now is if it's true emergency and they're just trying to get the baby out. Sometimes they'll still do a classical, but most of your incisions will be low. Okay? Let's talk about VBACs. Vaginal birth after cesarean. There are some safety things we need to consider. We would prefer that they've only had one previous C-section. They have kind of laxed up on that a bit, but we don't want them to have had 6 previous C-sections, okay? We need to confirm that the reason for the first C-section has been corrected. So let me give you an example. Her first baby was breech, this baby is vertex, okay? Her first baby had a C-section because the heart rate dropped. This baby's heart rate looks fine. Mom was preeclamptic severely with the first baby. It is not preeclamptic with this baby. However, if we did that primary C-section because the baby was 8 pounds and we think this baby is 8.5 pounds, then we did not fix that, so they would not be a candidate for a VBAC. The biggest risk, or the risk that we see with a VBAC, although it be a very low risk, is something called uterine rupture. And if that happens, it can be detrimental for mom and baby. So the incidence of uterine rupture is usually less than 5%, so it is a low risk, but if it happens, it can be catastrophic, okay? So let's talk about the signs of uterine rupture. Vaginal bleeding, fetal distress, and this weird abdominal pain that often radiates to their shoulder. If they are having a VBAC, the only medication that we typically use for induction would be low-dose Pitocin. We're not gonna use Cytotec or some of the others, but we can use low-dose Pitocin. And we have to have anesthesia readily available should the uterine rupture. We will proceed immediately to an emergency section.
Alright, so vaginal bleeding, abdominal pain, and what was the name?
Abdominal pain that often radiates to the shoulder, and then fetal distress. And when it ruptures, a lot of times, whatever baby part is right there will protrude through the rupture. So you may get this really weird shape to their abdomen and this really weird contraction pattern because the body's like, I have no idea what's happening, kind of thing. All right, I'm gonna skip protocol because it's on the next slide. Of course, your pain management options for your C-section patient are gonna be a little bit different, okay? So they're gonna get a spinal. We typically they're probably gonna need some narcotic for pain relief because this is a major surgery, so if you get to see that while you're in clinical, it's not a delicate procedure, I will just say that, okay? I'm not gonna go through like your pre-op and your post-op, it's gonna be the same as it would be for any other surgical patient. So, which y'all talked about, 113 still applies for these patients as well. But let's talk about your skip protocol and how it affects our patients. This is a lot of stuff, so I'm just gonna hit the ones that affect us and then I'll recap it at the end. All right, prophylactic antibiotics, so they're gonna get antibiotics 1 hour prior to incision being made, and they will get doses up to 24 hours post-delivery, okay? So they're gonna get prophylactic and post-delivery antibiotics. That's part of your skip protocol. It's gonna cover your first 3. 4 does not apply because these are not cardiac patients. For this one, for your hair removal, the key is we are going to clip them and not shave them. If you shave them, it takes off that first layer of skin. It's gonna increase the risk of infection. I don't know that clipping's really much better, but that is what we do. So clip, don't shave. For this one, urinary catheter needs to be removed the post-op day 1. So the day after surgery, the Foley catheter needs to come out unless there's a documented reason to keep it in. So get the Foley out as soon as possible. We're also going to monitor their temperature very closely. Remember, the ORs are cold. It's done to prevent infection. But once they come out of surgery, we need to get them warmed back up to a normal body temperature because a low temp increases the risk of bleeding, okay? So that usually just requires warm blankets, but if we can't get their temp up, we can also do some type of, we call them bear huggers, where it blows warm air on their skin, so you put it under their blankets and it kind of gets them nice and warm. So we do have some options. Moving on to the right-hand side, we're not gonna cover the first one, and the last 3 all deal with DVT prevention. So for our patients, we use SED pumps, so they will need to be on the pumps while they're on the operating table and up until they are up and moving at their normal pace. So in that postpartum period as well. Our patients in the postpartum period are higher risk for DVTs anyway, so we wanna make sure we prevent that. We do not routinely give anticoagulants, so we usually just use the SED pumps. So let's recap. They're gonna get antibiotics before surgery and after surgery for the first 24 hours after. We're gonna clip them, not shave them. We're gonna DC the Foley the next day. We're gonna monitor their temp and heat them up or warm them up as needed. And we're gonna make sure they have SED hose in place. Fair enough?
So why do we not use anticoagulants?
Because they're already having some bleeding. So I'm not gonna say we would never use it, but it's not routine. So for our moms that didn't have a C-section, we use early ambulation. For our moms that are C-section, we use SED pumps. So unless they have some other reason for us to do it, we typically don't because it can increase their bleeding. Questions? We're not done, but we're close to being done. We're just gonna do some fetal heart rate strips.
Okay, so would anticoagulants be used like, you know, what is it, the cultural patients that need them rest?
If they are on SED pumps, that's usually enough, cause it's gonna mimic walking. So
Right.
if they're agreeable to that, that's the less invasive thing. If they are not, then it is possible we would put them on some type of anticoagulant, yes.
Okay.
Probably some Lovenox. Okay, let's look at some fetal heart rate strips for the next 20 minutes. I was hoping, oh wait, no, it's just 6:39. We got plenty of time. I'm sitting over here panicking because I thought it was 7:39.
You keep panicking.
Do y'all wanna take a break?
Just a smidge.
Rock on.
Let's take about a 10-minute.
You can
I was just pushing through.